So welcome, and thank you for inviting me to speak this evening, and I hope that I can answer some of the questions. I thought I would start off by thinking about this a little bit over the last month or so since I was invited to speak, and I've put together a slide with a few thoughts on it, and I was just going to talk around those a little bit and then answer any questions that anyone has and do my best to sort of resolve some of those if we can. So for those of you that don't know me, and it's really hard, I can't see exactly who's on the call. I know I can see a few people I know. I'm a haematology nurse of over 20 years experience working in the area. I'm amused when I get called an expert. I'm not. I just have experience of working with people with haematological issues and conditions. I have a particular special interest in bone marrow failures such as aplastic anemia and PNH, and those of you that know me know that. And that stems from the first patient I ever looked after on a haematology ward down in London who did have a diagnosis of aplastic anemia. And I ended up being part of his care while he went through a bone marrow transplant due to different issues at the time. I'm pleased to say he is still doing well. I am happy to answer any questions as we've already covered, but we'll come back to those in a little while. I am quite an unusual beast in the sense of I am just a nurse. I am not an educator, but I like to share my experience. There's not many people that have had the role that I've had. There's only one other nurse that I know that has taken such a big interest in this area, and he's in Melbourne in Australia, and he is my support. As we all know, that helps us get through. Across the country, I know all of you will have different experiences and had different experiences with the healthcare system, and what I appreciate this has been very varied across the different areas. We are funded as doctors and nurses within a PNH service, but because of our interest and the overlap of the two diseases do end up being referred to, many patients referred to us for support with aplastic anemia and bone marrow failures. Not so much in the MDS and myeloid, because here at Leeds we have quite a big myeloid team, so that tends to go there, but we do work closely alongside them. And in my previous role, I was very involved with the care of people with MDS, so I have some experience there if there is particular questions. I know there's access to support across the board, but I thought today that we would just cover a little bit around aplastic anemia and PNH and how it occurs. And a little bit around treatment. I know in current climate, practice has changed and continued to evolve a bit like an enforced industrial revolution, I guess, bringing more access to specialist care in some ways, but making access to everyday care slightly more difficult with blood tests and different things, as I'm sure you've all experienced. Trying to get them in the pandemic has not been straightforward. They're not seeing us face to face. And I can guarantee that we as healthcare professionals are missing everybody as much as anyone. And so the slide that I put together, I don't know if we can put it on the screen at the moment.
Of course, okay, 1 second. There we go. Hopefully that should show in a moment.
Yeah. So it's not by any means an exhaustive list. It was just some thoughts I had around the different areas we might cover. And I sort of used it as an aid memoir a little bit for myself, but also to tackle some of the questions that I have seen in advance. But I hope this helps for us going through this evening. So aplastic anemia, and those of you that have lived with it for a long time will understand that it can be something that is acquired. It's an immune disease, but it also can be something that's inherited. But this is very, very rare. We don't see that very often. In my practice, I've seen very few cases across the years of someone that's had an inherited aplastic anemia situation. And those that have aplastic anemia, the biggest question I always get asked is why? Why me? Why did it happen? And that's something we've very, very much struggled to answer. There is the odd occasion where we can come up with an answer due to something that has happened in the patient's life just before the aplastic anemia diagnosis, but generally we do not know. And like I say, there's a crossover with the myeloid type illnesses such as MDS, and often gets pulled into that same bracket. And I think in some of the more smaller hospitals, you will very much be surrounded by patients with that diagnosis rather than aplastic anemia, and that's where the experience comes from with the experts looking after you. The name in itself, aplastic anemia, can be very misleading. All blood cells and all lines are affected, not just the red blood cells, as often is thought with it being anemia. And aplastic means any condition in which the body is unable to produce new cells or tissue. So when we talk about it, we often talk about a term called Pancytopenia, which means all cells few. So the anemia is the red blood cells where they are reduced, thrombocytopenia, which is your platelets where they are reduced, and neutropenia, which is where your white cells or your neutrophils are reduced, which is the part that fights your infection. So it can be different to other bone marrow conditions where we look at a bone marrow sample. There are fewer immature cells, so that the cells are not being made, that they've all gone. Whereas in something like MDS, you see a production problem. So I always think of it in the sense of in a factory of a car, the wheels are put on the roof, for example, in MDS, whereas in aplastic anemia, they're just not produced. The whole car is not produced, if that makes sense, and understand my crazy brain and how I understand things. So it is very rare. It's about 120 to 150 people in the UK a year that are diagnosed, or 1 to 2 million in Europe, which is incredibly rare and can be very difficult to diagnose if it's not thought about in the sense of a possibility. However, once it's a possibility, it's quite simple by looking at the full blood count and confirming that with a bone marrow test, as I'm sure some of you or all of you have experienced on the call. Like I say, there's about 70% of patients diagnosed. We don't know why it's diagnosed, and the medics amongst us would call it idiopathic, a word that always flummoxed me for a long time in my career. It just means we don't know any obvious reason. The reasons that we have found that people have had aplastic anemia is in the sense of viruses, which obviously is a very hot topic, and we'll come to a little bit in a minute. Chemicals, some medications, chemicals, like I have known someone that was a farmer that had post-spraying some crops, but it's not something that's common and not routinely seen. And it's very important when we first meet someone, and you'll wonder why when we first see someone, we talk for so long and ask so many questions to understand that history and if there is anything that can relate to that. So we look at the red blood cells, like I say, which carry the oxygen and the hemoglobin levels, and we train and educate people very well to look at these levels alongside the white blood cells that fight our infection and the platelets that help our blood clot. So the low levels that we experience with these in aplastic anemia can be very challenging to daily living and can impact in different ways. Not having any neutrophils makes you very nervous from the point of view of infection, and right now has been the biggest thing with the isolation. And I know I've already seen a few questions before I started speaking this evening to answer that, and I will talk about that a little bit more. We often look at other blood counts around it, and obviously the chemistry to make sure the kidneys and liver are working, and that can be affected by disease or also treatments that we give. We do have a criteria for diagnosing aplastic anemia, which I can go into more detail, but it's all to do with the changes in those blood levels. And we go from very scientifically to non-severe aplastic anemia to severe to very severe. The terminology was well thought out there. Sometimes I feel that has a negative connotation the way it is presented, but it is very clear in what it means, I guess. And obviously our biggest thing is the worry around risk of infection and someone presenting acutely unwell. But remember, even a very severe case of aplastic anemia can be treated successfully. The PNH clone, now, as those of you that know me, I can talk about PNH all evening, and we will still be here tomorrow morning. But just to sort of mention it and introduce it, is something that exists alongside aplastic anemia in the sense that it would only occur in somebody that has bone marrow failure. So it can occur in such as the myeloid conditions as well, but you have to have the immune attack going on and the bone marrow not working well for the PNH to have a survival advantage. So that can be transient and can be an aplastic situation that you never know about, or it can be in the setting of someone with a severe or very severe aplastic anemia. And often in those cases, we will treat the aplastic anemia and monitor for the PNH, but sometimes it can come alongside, or it can come 2 years after treatment for aplastic anemia. It is no rhyme or reason to when that can occur. And in a marrow that doesn't have any bone marrow failure, the PNH clone doesn't have a survival advantage, which is why it's so rare, because you have to have 2 events happening at once for it to happen. So you can have aplastic anemia without the PNH clone being there. So then obviously you don't develop PNH. However, when the both are alongside each other, it's a possibility. PNH in itself are stem cells that live alongside the normal stem cells if they are there, and they do produce blood cells in the same way as a normal stem cell does. But what the blood cells that it produces are just slightly weaker, so then bring complications of the disease. And they can be things like making the platelets more sticky, or the red cells more prone to hemolysis, which is breaking them down. So it comes with complications, but only at a certain level and only if it happens. For those of you that have a predominant PNH problem, I know that is very, very significant and requires treatment, but we can manage that in the same way as treating something like severe aplastic anemia. However, to talk about that a little bit more detail would be something that I think is important. It's hard when you talk about bone marrow failures, because I think that if you say you have a headache, then everyone around you understands that you've got a headache and what a headache involves. If you say you've got something like aplastic anemia, everyone thinks, what's that? Is it you're anemic? Oh yeah, I'm anemic. My auntie was anemic. You know, there is a level of understanding to that. So that's where I tend to use the term bone marrow failure, because it makes a little bit more sense to somebody that you have a problem that generally that can be quite serious and that is affecting daily living. We do focus on blood counts and we do educate everyone around those, but also one of my aims in my role has been very much to move away from that, so that it can be something that you live with and forget about. But I know at different stages along treatment pathways that is not always possible, but that's the aim in the long term. And living with something like aplastic anemia can be a marathon and not a sprint. And as has been expressed in some of the questions, it can be something that is very, very difficult. Whereas if you talk to someone that maybe went through treatment such as a transplant or ATG 10 years ago, they would view it very differently to they did the first year post that treatment to 5 years post. And that's very, very significant. And I think that was very much highlighted to myself when I had an acute situation and had a hemoglobin of 6 and argued with the medic that's saying that I think I've dropped my hemoglobin. And that feeling of how I was with a hemoglobin of 6 was more something I understood for the first time in a way that I had never understood before. And I don't want to talk about it in the sense of it's about me. It's about that understanding of what is going on in someone's body and how it affects them. And that understanding is something that's very, very significant. And I think that's very much where I look to peer support and buddy type systems for bone expression, which I know is very across the pond kind of way of looking at it, but it is having someone that's been there that understands it can be the best support, more so than even the healthcare professionals. And I think groups like this is the key to that. We can enhance it, but we can't give what the person that's already been there has felt. So symptoms, when I talked about symptoms to myself a lot yesterday, I wrote a list, and the list is massive, and I know how massive that is, and I'm sure that we could add to it if we talked about it as a group, and maybe we can. Next to symptoms, I did write fatigue, because fatigue is the main focus, and I think no matter what your diagnosis, whether it's a severe, non-severe or PNH, fatigue is a big issue. And I think if we break that down and look at that, and I think as a nurse in my role, I know that that is the bit that can be very, very challenging, because we may get through it all, maybe 5 years down the road, but there still is a level of fatigue there. And I think we have to give credit to the body for that, in the sense that we have given treatments. You may still be on treatments, even though they've become routine, a part of daily life. You may still be taking a low level of cyclosporine or tacrolimus or one of the complement inhibitors. There is still that there, but also in the sense that there is sometimes an underlying level of the disease there as well. Plus, I think the body has experienced something that changes us and changes who we are. So it makes it more difficult. And that level of fatigue is very, very individual to the individual. And sometimes even when someone is made better, the hemoglobin may sit below normal range. And we don't always give ourselves credit for dealing with that. I wish I could say I had a magic solution, but I think one of the things that I found is finding it a normalization of that, and how that works in your own individual life, in the sense of how you manage that against work, university, all the different things that are involved. And we can talk about that a little bit more in a more discussion type way. The other side effects I've got, sometimes I think are caused by the medications that we give. It's very hard to isolate them against the medication and the underlying condition, but also how we cope as human beings with having that condition and those drugs. There is obvious things like the anemia will bring the fatigue because it upsets the chemistry, it makes you more tired, your body and your organs are affected, but also the things like mental clarity, all those things that we've just talked about where you've had changes, it will make you more likely to be forgetful or find your way through it. I know people say that they really struggle to remember things or even just to get a clear thought. And I think sometimes it's comparing yourself to how you were when you were poorly, and not always to how you were before, but also just building on that and working our way through it and doing it sort of day by day in the same way as the fatigue. Sometimes it doesn't go away, and that's something that's quite hard, which then leads to more of the mental health side of things, which, you know, there is ways and avenues of dealing with mental health, whether that's psychological support or peer support or other patient support or your healthcare professionals. It's just finding that thing that works best for yourself. Insomnia is often medication alongside the thought process, shortness of breath, the anemia, headaches. There's a whole different way, but I can address any particular questions as we go through. Treatments and the treatments that we give for aplastic anemia in the non-severe setting, it's often supportive care. So supportive care can be anything from blood transfusions to erythropoietin and folic acid. Folic acid, I would advise anybody with any hematological condition to have folic acid. It's a simple vitamin that helps build red blood cells and is something that's so innocuous that it's easy to take if we remember. We're all guilty of forgetting. To treating with a bone marrow transplant in the very severe setting if we cannot get responses with immunosuppression, or in those that are below 40-ish, depending on the clinician. That level of cutoff of who's a young patient changes as they get older, in my experience, which is a good thing from the point of view of treatment, but also immunosuppression from ATG and cyclosporin or tacrolimus alongside things like L-trombopag. And I know there's questions around the side effects of those, and we can talk about those, I think, openly together rather than me listing through them. Other drugs we use like antifungals to prevent infections. We give sometimes growth factors to help stimulate cells, or iron chelation to take away the blood that we give you is full of iron, so we take that iron away again. All those kind of things I'm happy to address a little bit more as we go through. Chronic was one of the words I wrote, which I took off there. I think one of the things we don't give that title to at the start, but I think sometimes changing that mindset that this is a chronic disease and can go on for a long time can help somebody get through it and manage it on a long-term basis. That generally you will have some involvement with the hematology over the years, even if it gets to a yearly checkup, to reassure that the blood counts and things are still stable. And living with it, you know generally that you're well and that you're getting on fine, but obviously it's nice to have that reassurance. Information, employment, holidays, those side of things. Information is hard to find in a rare disease, and I've always been guilty of promoting myself, like giving out my email. I'm always happy to answer questions, as I think the same. I think it's wonderful what's been done, and that's not just because they've invited me to speak tonight, but by the Aplastic Anemia Trust and PNH Support and PNH Scotland. I often direct patients as well for more generic information to Macmillan, and I know that's for cancer, but some of the stuff translates across. And I don't like the distinction of it only being available for people with a cancer diagnosis, because I don't think there should be a distinction. Also going through like Maggie's and Maggie centres, which are dotted across the country, but are available online as well. Citizens of Rice and social workers, you know, I know everybody's slammed at the moment, but there's still support there sometimes with getting financial aid and different things. But also the most importantly is your local team and your CNSs and asking them, but if not, asking them to ask someone else, such as us or the team at King's or different centres across the country that have a big interest in this area. I know it's not always easy, but there is ways of doing that. And, you know, people like myself that exist would always help support and help you find that, as would, I know, Sam and the guys at the Aplastic Anemia Trust. The hematological teams, although they may not be part of a national service and exist alongside us, we do all work very closely. And we do get regional referrals and see patients as one-off, but also there is a lot of experience there, and sometimes it is just tapping into the right people within the department. And I know that can be very difficult. We can always help with the advice around that, but collaboration and working together and finding that trust in the person you do trust at your local centre can be the key to getting through this journey. I know it is a partnership, and it is something that is quite hard. And sometimes it's the late effects or what we do after treatment and how you go back to living in a normal way after it. And I've known so many people that have changed their roles, changed their life, done so many different things after having an experience like this. And sometimes it opens up a whole new world. But in other ways, it's just that first year post can be really, really difficult to work through. And I think that's where you do rely on coming to meetings like this or speaking to people within the area. I can't value that enough. As a nurse in the area, I always think that that's my role, and I'm happy to do that. No questions silly or stupid, or no questions too difficult. I don't claim to always have the answer or the right way, but I think my colleagues as hematology CNSs across the country would feel the same, that you'd rather be asked and find an answer than have someone not ask you because they're worried about it, and do that. I think on my list here, I've got lots of other different things, but one of the things that came to my mind when I was thinking about it, and then I noticed from the questions that were sent through, was about pregnancy. It's one of the things in aplastic anemia we talk to ladies and gentlemen a lot about. Pregnancy is all about keeping mum well, and that keeps baby well. In the setting of PNH, when I first was involved with people with a diagnosis of PNH, pregnancy was something that we tended to advise against because of the complications of thrombosis. However, since the onset of complement inhibition, this has been something to be impossible, and we've had a bit of a baby boom, and it has been one of the things that's been the nicest part of my career over the last 15 years or so. But what I always advise is that if that is something that is being thought about in the setting of aplastic anemia or PNH, is involving the haematology team straight away. Obviously, appropriately, if you're planning it, get advice. If it's unplanned, you know, get advice as soon as you can afterwards. And it is something that is possible and successful. However, in aplastic anemia, we do sometimes see a drop in blood counts, and there is support required in the context of treatments or platelets and transfusions. However, things normally settle out afterwards, and it is a manageable situation. It is possible to get a relapse, but it's something that is not common. And then I think with things like the current climate and COVID-19, as I think a lot of you all know, if you're involved with the Aplastic Anemia Trust, we've been funded here in Leeds to do a study to look at vaccinations and how we navigate out of that. I'm happy to discuss it, but I think from a top line point of view, our research that we've done here has shown us that we are seeing similar responses to the general population in people with a diagnosis of aplastic anemia PNH. Maybe not so good to the first vaccination, but once the second, third and fourth are given, we are seeing good results. Our study so far is only really clear on the first two vaccinations. We're definitely seeing a good response to COVID-19 vaccinations. And there has been a lot of concern and a lot of chatter around that and whether it would see relapses in aplastic anemia, but it's not something that we have seen in our practice here. There's been a few cases across the world, but nothing particularly in the UK so far to report. We possibly have one patient who had an aplastic event post vaccination who didn't have aplastic anemia first, but it's impossible to isolate that at current. And I know opening up of the world is kind of scary. There is some changes, and I think we'll talk about it, but the onset of having treatments has given reassurance for those that may require an antiviral to support them if they do get a diagnosis, and we can talk about how practically that works. We have identified patients that may need a little bit of support with that, and they can have a letter and have a PCR test that's at home, so you can get a result straight away and get treated within 5 days of a positive case of coronavirus. It is really hard, and really appreciate that. And I think it is just working our way through it day by day and trying to find the best way forward and coming out of isolation in a way that is appropriate to every individual. And I think opening up and talking about that will be helpful to everybody. I think going on with an employer and getting support from the HR, but also doing what you're comfortable with doing, and finding that place there. I know someone's asked about holidays and travel, so we can talk about that, but I think we've always gone by the lines of working along what the government guidelines are for COVID-19. However, in a common way of aplastic anemia, in the sense of not just about COVID-19, we've always talked about travel, and everyone wants to go away, which is quite understandable. When we've abused you for 12 months or whatever, the first thing that I would want to do as well is get on a plane and go see somewhere different from where we've been for the last while. There is anxiety around flying. That's more around blood counts. And I know some local haematologists will say, don't fly. We've always been quite chilled about that, obviously within reason. If someone's counts were completely flat, we would advise against it. But as counts start to pick up on an individual basis, we do recommend that people do travel and get away and do what they want. Yes, it's what you're comfortable with. You know, going away in the UK and going in a camper van may feel better and just as nice to getting on a plane and going to the other side of the world. But I think it's just working that out. My biggest thing is getting insurance. The amount of times I've had to deal with different things where someone hasn't got an insurance, and it can be more complicated. Somebody who had a blood transfusion in America had to spend a lot of money on that because their insurance didn't cover it. It's not saying don't go, it's just thinking about that before you go, so you can go and enjoy it and hopefully never need it. You have to build that cost in, because I know it doesn't come without a good fee. But lastly, I think I just wanted to talk about it being holistic and trying to bring it together, like managing the consequences of the treatment, information, financial side of things, and worker support. That's what we're trying to do, and try and support that, and very much hope we can. But I'm happy to take your questions and talk about it. I know there's a million other things that are on the screen, but I think that's a good place to start, if that's okay with you, Sam.
That's wonderful. Thank you, Louise. So I'll stop sharing the screen for now so we can see all of our lovely participants again. Excellent. So, as you'll know, Louise, we have had a few questions that have been submitted in advance. So I think it might be wise if I just start with them first. But
okay.
Likewise, anybody that's here, please do feel free to pop questions in the chat or unmute yourselves and chip in as well. This is a really good discussion to have as well, so do feel free to join in. I'll start with Sharisa first, because she submitted a question in advance, and I can see one in the chat as well. So Sharisa's daughter is 12 years old. She's suffering from very severe aplastic anemia, and she's now 2 months post ATG. Generally, her daughter's been having quite a difficult time at the moment, understandably, with the treatment. And Sharisa's just asked for any kind of techniques that she can use to just support her daughter emotionally and practically to get through the recovery post-treatment and whatnot.
Yeah, it is a difficult one, and I think with someone of that age, it is a challenge, because it's the understanding, and you do have a very good understanding at the age of 12. Hi, Sharisa, I can see you now. And I struggle from the point of view of apart from being practical, it is finding the things that work for her. It's very hard. I think in the sense of helping your understanding there, that makes more sense to your question now for me, is that if someone has had ATG, and there'll be people here that I know have been there, if you see a response, it can take 3 months completely, because I always look at it in the sense of, and don't take this in the wrong way, like an oil change, you kind of resetting it all and putting it back. Whereas with an oil change, you get an instant response. With this, you're basically waiting for them all to grow, as you sort of eloquently pointed out. However, it can be that sometimes you get that response at the last minute, but maybe sometimes as you watch it, you start to plan for if that doesn't. So it doesn't always mean, and I always say this to every patient, we might start planning something different, such as adding in another medication or having a thought around bone marrow transplant, because those things can take a while to come through, whether it's for funding, dare I say it, I hate that, but it's reality, or whether it's finding a match in the sense of a bone marrow transplant. So if that ball is rolling, it can be stopped rather than anything. And I think sometimes that's not always explicit in the way we tell people that. So it's not that we're saying it won't happen, that we won't see a response. It's more like, if we start thinking about that, then maybe we've got the plan in place. Otherwise, if it doesn't, and sometimes it doesn't, and we do have to add other things in or go to a different option, that you have that already almost in place, because doing a transplant is not something we can do quickly and easily always. Sometimes it is quite straightforward, but not always. So, you know, things like finding the matches and different things can take a while, then obviously going through all the checks and everything. So it doesn't always mean that's what is jumped at and going to be done. But I know when you're sat on the other side, that can be really hard. I think for a child to navigate it is hard, and I think the isolation and the communication bit is emphasized even more, and it is something we're very used to, because that's what we do to the patient group before COVID, but now it's, I think the only thing is that people understand it a bit better, and with technology as it is, it's engaging your child in that way, and using technology as it is, interacting that way. But there is no easy solution apart from the day-by-day kind of goals and giving them those, and I'm sure you're already employing some of those. But I think it's also sharing your frustrations or questions with somebody else that maybe have been in the similar situation, that I have found has worked the best for most people that have, especially a parent. I think it's harder than being the patient sometimes for the parent to, or the carer. It's not, but it's different anxieties. And, you know, if you're dealing with being unwell, you're dealing with that. Whereas if you're dealing with someone that is unwell, that can sometimes be hard to express and manage. And I think the only other people that really understand that is someone that has been there as well. And I think that may help you a little bit. Does that make sense? Yeah.
That's wonderful. Thank you very much, Louise, and thank you, Sharissa, for sharing your experience as well.
Yeah.
And we,
I know it's hard.
yeah, we all wish you all the best as well. I know you post a lot on the Facebook group as well, and it's always lovely to see the progress and everything like that. So thank you very much for sharing that. Lovely. So the next question that I've got is from Zoe, and this is a question that we get all the time at the AAT, and it's a hot topic. How can I get safely and easily back into exercise after receiving treatment?
Yeah. I always look at this about what you did before a little bit. And I know I've just talked about resetting and rechanging your life, but I think also to answer Zoe's question, it's very much about graduating it, starting slow. And I know that's really obvious. It's the same in the situation of if you haven't done exercise for a long time, it's the same kind of thing. But I think it's being mindful and careful. Obviously, if the platelets have recovered, that's easier. But if obviously there's still a lower level of platelets, then you have to be careful around contact sports and things like that. But I think also it's just gradually introducing it and seeing how your body will allow. I've known someone that's, you know, a world athlete have aplastic anemia and go back to competing. And their starting point was at somewhere I couldn't even achieve now as someone that hasn't been unwell. So it varies a little bit, but the practical way about it is testing the body and doing something once a week, increasing that to twice a week, and then increasing it as much as you feel is appropriate, and whether that's where you stay, but also trying different exercises and getting a bit of advice from somebody that is up on fitness programs, not necessarily in the world of hematology, but just on a fitness program, and gradually get them to build up with you and give you that positive encouragement and support with it, and give yourself a goal just to work through that program.
Fantastic, that's great. And I'm sure that would be very useful advice for many people in our community as well. So that's great. Thank you, Louise. The next question that I've got is from Katie, and it's a specific question about Eltrombopag and its side effects. Katie's reported that she sometimes experiences nausea and some digestive issues with Eltrombopag, which we know are quite common side effects. And she's just asked if there are any kind of like tips or advice that you could offer for maybe helping to cope with those side effects.
Yeah, I mean, Eltrombopag, as those of you that have taken it know, it comes with some complications, and it is a great drug if you can tolerate it. But I will say straight up, not everybody can tolerate it, and it can be one of those things that is difficult. However, I think the side effects are often made worse by the fact that it has to be taken 2 hours either side of dairy produce. And I have known people take it right at the end of the day as they go to bed, or set an alarm at like 4 a.m. and have it in the middle of the night. I don't know why that sometimes seems to have less impact on those symptoms, but it doesn't work for everybody. I think, you know, having it at the end of the day sometimes just seems to be that there isn't as many side effects, but that doesn't always work. But that is the sort of best way we've found to manage it. And the people that are brave enough to wake up at 4 a.m. with an alarm, take a tablet and go back to sleep, sometimes that seems to work as well, but I don't advocate that, because obviously broken sleep's not going to help you get better either.
Brilliant, thank you, Louise. We've got another question from Elena here. I don't think she's with us today, but I'll ask the question anyway.
Okay.
I believe Elena has she'd had ATG twice, which unfortunately hasn't been successful. And there currently isn't an available match for a stem cell transplant. And she'd asked what other potential options may be available for treatment. We know this is obviously quite a difficult question sometimes.
Yeah, I mean, it is something that there are other medications that we do try. We do look at some of things like danazol on that, which are like anabolic steroids. We do try Campath. Sometimes we do re-challenge with immunosuppression, whether that's in isolation of just something like tacrolimus on its own. Sometimes trying a different medication can give an impact where we've not seen it with others. There's not always a clear, obvious way that would be more efficient in getting a response than what's already been tried, but sometimes that happens, and I think that's where we are very individual in how this immune attack affects us as people, and how our bodies are all different. So sometimes someone just responds to something else different to somebody else, and the standard treatment isn't always the best approach. But the curative rate and the response rate is so high in those that it is an appropriate way to tackle it. I think there are advances with transplant and finding different matches, and using haplo is now a very good option and much better than it was 10 years ago, and it's worth exploring that and continue to explore the bone marrow register. But I think the other drugs that are out there, such as danazol and oxymethylone and Campath and things, can be an option, and it may be worth speaking to somebody at a specialist centre. That's okay to ask for as well.
Fantastic. Thank you, Louise, for that. The last pre-submitted question that we've got here, so everybody else, please do feel free to chip in, unmute yourselves, post questions in the chat as well. We've still got 15 minutes to go, so plenty of time there. The last question that I've got is from Natalie. She's asking, she's still generally shielding because she feels safer doing that, and she's quite severely neutropenic at the moment. She's asked, is there any information available about new potential treatments that are available, or indeed prophylaxis for people that are neutropenic, to protect them during the pandemic and things like that?
Not in protection apart from the vaccinations. I mean, currently, as I already mentioned, the vaccinations are where we're seeing good responses and have changed the picture, and we've seen a much better outcome from people getting COVID-19 with vaccinations. Yes, you still have a virus and unwell, but not the complications that we saw pre that. I think, as I mentioned before, if someone is in an immunocompromised way or on medications such as cyclosporine and things, then and are identified as vulnerable, then there is that possibility of having the PCR test at home and dealing with a positive case. But otherwise, at the moment, there isn't anything further than that. I think it's using common sense, and I don't mean that in a patronizing way, and don't take me the wrong way. I think it's, you know, in the same way as when before the pandemic we'd say avoid crowds or people that are infected with the cold and things like that, avoiding going and sitting in a big stadium full of people. But also I think in reality we have to build our sense of where we fit now in society and how we can move forward and get out there and overcome some of these obstacles. But I don't think there is an easy way of doing that, and I think, you know, as healthcare professionals we've gone through the same thing, learning on the day, you know, the same as anyone else. But I think in a positive way it is that they're using that in the back of your mind, that there are good responses to vaccinations, there are some antibody treatments there if someone was to be unwell, and looking at it more as something that is treatable and manageable in the same way as we have issues with flu and other infections in society. However, I know that's not something that we can switch off after what we've been asked to do over the last 2 years. I'm happy to take a response to that, or any thoughts.
Of course. Again, everybody here, do feel free to unmute yourselves or post in the chat as well. We're very open to a discussion there.
No.
Nicola, go ahead.
I think, like everything, it's not been 100% cover, so there's no harm in asking your local team or your GP for more information around that, without asking more personal questions. I think that that's the way to manage that the best, and just asking that question if it is a possibility for you, for yourself or family member.
Nicola, that was something that I actually had a meeting with the Blood Cancer Alliance earlier about the issues with people accessing these PCR tests and things like that. It seems initially, as we know, the rollout has been a little bit hit and miss for people with aplastic anemia and PNH, but we are certainly pushing for the NHS to try and include people as standard with those conditions as well. So fingers crossed anyway that we can get some action on that. So
yeah, and I think it's the same from our side. We, you know, you're in more of a position to be able to admit that than us. We are pushing for that from our side as well. But you know, it's complex, isn't it, in the sense of getting everybody, and when that's where I made the point about it being a rare disease. It's sometimes hard to get that understanding. One of my biggest frustrations of it shouldn't be any different, so you should be able to access that, but sometimes it just takes a little nudge.
Absolutely. I've seen so many times recently the official criteria for the antiviral treatments and things like that, it specifies malignant hematological conditions, whereas obviously AA and PNH, they're not cancers. So there is that little bit of confusion there at the moment. So we're doing our very best to change that at the moment. So lovely. I've got another message from Maria from PNH Support in the chat as well. Maria says, "Hi Louise, do you know what is happening re patients being advised about access to antivirals if they get COVID, as many people haven't received a letter, in addition to not having letters about the fourth vaccines? I'm aware that there are cohorts of patients who haven't been notified." That's kind of what we were just discussing as well.
Yeah,
so, yeah.
Thanks, Sam. So we were at this meeting with Blood Cancer UK today, and it seems that there is some more chaos going on about groups of patients that haven't been notified about and I just wondered, I know I was aware some patients had been, you guys were sending from Leeds some sort of notifications. Is that what we need to do, is contact our team to get a letter, or do you know?
I think that's the easiest way. I mean, I think it got a bit lost because as we rolled out the third vaccination for people that were classed as vulnerable or clinically vulnerable, it was as the booster came out. So I think it got a little bit confused in the message. So the third vaccination should have come and then a booster. But obviously, because the government then rolled out the booster for everybody at the same time, it got slightly lost in translation. We have tried to cover that from a way of, like, some people that we've identified as requiring that, but we do send out a letter if there's anyone that requires it from our care. We've just sent out a letter. So the best place is to ask if you're under the care of the PNH service or your local haematologist, and if you get stuck with that, then obviously we can support trying to get that. I'll get shot by the doctors for mentioning that. We'll support it, but there is a way, you know, around that, and I think that's the best way, is ask your local haematology team or the GP. If not, they should be able to issue it as well.
Absolutely, we were told that by Blood Cancer UK earlier. There are other options available if you know, a letter hasn't been forthcoming from the NHS and things like that. There are other referral pathways for treatments and whatnot. So
yeah. I mean, we've shared that information, you know, at a national level, and it should have got through. So sometimes it just doesn't. And I guess there's such a big machine happening at the moment of trying to get that.
Of course, yeah.
It's no excuse, because I don't agree with it either, but I have to be.
Lovely. We've got another question from Sanjay in the chat as well. She said, "Hi Louise, thank you for the talk, it was very helpful. Only one question. My son has recently been diagnosed with severe aplastic anemia and is 2 weeks post ATG. How are we as a family supposed to carry out day-to-day activities? Are we expected to isolate completely or just reduce the risks wherever possible?"
I think we have to be realistic, and I think it's reducing the risk as much as possible. I think that being at home with your family is the most safest place. You know, I know being in hospital, we can react and look after things, but there's risks in hospital. Being at home is where you should be. Obviously, if somebody in the family, and this is pre-COVID, has some kind of infection, we do try and separate that out. We do advise like the family members to get things like flu jabs, and obviously now COVID-19 vaccinations, and look after and avoid obvious risks for that period of time where someone's counts can be very low and more vulnerable to a risk of infection or complication. And it's just managing that as best you can. I know it's not always possible when you have a young family, but it's trying as much as possible to do that in that way.
Wonderful. Thank you, Louise. Do we have any more questions, anybody? Don't be shy.
One of the other things that I was thinking about was the wellness and well-being and self-care. And I think we all have a responsibility to do a bit of that as well. And I think it's very easy for us to make people reliant on the advice and support that we give, but also it's motivation and support to get that responsibility back to ourselves, you know, and it's difficult after being unwell, but I think it's finding that place and something, you know, and I don't mean it in just a spiritual way, I mean it in like walking the dog, for example, and I put that in inverted commas. I don't mean physically having to have a dog and going and walk one, but it's finding that little bit of space in the day for ourselves to motivate. But also, you know, if you go out and walk around the block once a day, if that's what you can manage, then that will help rebuild and self-care and get that wellness back, which helps with general well-being, and supporting, you know, moving forward a little bit as well, and taking that responsibility for our own self-care. And, you know, don't get me wrong, I'm a nurse, I'm the last person that should be saying that, because nurses are notoriously bad at looking after themselves, but it is something that I have to remind myself as well. And my dog's a lot happier since I've walked her more. Without sounding like I'm not answering the question, it's very individualized. So it depends on the person that's receiving the treatment. So some people will continue with a level of blood counts that aren't in normal range, but will be well enough to carry on with daily activities of life and be able to work and things like that. In average, you would look at it from, you'd give it 3 months to work and then another 3 months to get a good response. So you would never do less than 3 to 6 months to see a response. But in combination, that can sometimes be varied and change a little bit. Whether there needs to be a change is something that's individual to the other side of supportive care, and whether transfusions or other medications are needed as well. But it's sort of 3 to 6 months where you would start looking whether you do need to change that. But that depends on the individual, because sometimes someone can continue for 18 months before a change can be made because things are stable. But if we want to see an improved response because there's concern, then you may add or change something at that point. But it's generally...
Right, her bloods are not too bad. She hasn't had a blood transfusion or platelets for the last 10 months now.
Yeah, so that you know can sometimes we see a a response that is not perfect. Obviously the aim is to get people back to a level of normal range of blood counts, but sometimes that doesn't happen. And I've known patients over the last 20 years that have remained with blood counts that are lower than normal range, but carried on completely with normal life. Apart from sometimes if there's a challenge, they may need a bit more support if there's an infection, or, may need a transfusion post that, or, if there's going to be a procedure such as surgery, if the platelets sort of level out at 60, you may give platelets to do a dental procedure or, a surgical procedure. But normal functioning of life can continue at that level. Obviously, your aim is always to get as good as you can. And that's why you continue a drug a little bit longer. And with things like tacrolimus and cyclosporine, you give the best possible chance, and then you give the body a while on that best response before you would reduce it and take it away completely. It may be that it's a level of the best response, and it may be a consideration to add something in or continue as is, depending on where that level is and how the quality of life is for her. So it is a very individual thing, which is why you can't say distinctly, I would do this or that. And I know that sounds like I'm not answering it, but it is the utter truth. We don't ever do it on a set of, like, in some cases, you would always say, right, if someone's got a headache, you give them pain relief. In this case, if someone has aplastic anemia, you would do this. We can't go down that route. It's very varied for the individual, and it can change very much so as time goes on. So even if you plan something, which I guess goes back to our original question, it can change direction and down a different path as well as time goes on. It's not always distinct, which can be quite hard and frustrating. And I can understand that from your side. Why do we add something in, or do we change something? But sometimes that's not appropriate, but that may change, and it may be that you reduce it or you add something in. Sometimes people need to be on something like tacrolimus or cyclosporine for a number of years, and maybe forever at a low level. It just depends on how that person responds and how their blood counts are if you take it away. No, I'm the wrong person to ask, because I think the neutropenic diet is important, but I think sometimes a little bit of what we fancy can make us feel better as well. I mean, obviously avoiding really silly things like shellfish or blue cheese, things like that. But generally, I think you should be all right. Okay. Once your neutrophils get up above 1 and that, you're generally okay as well. I think if you go somewhere where you know very well and there's a good turnover, then it's just if it's somewhere there, it's not been busy, and it's been sat around a while. That's the worry with rice. Salad these days, I think, is so well washed and looked after and protected. I think, generally should be okay as long as you feel comfortable. I mean, I would never do anything and advise someone to do something that doesn't feel right. But I think if you're in a restaurant, that has high turnover and, the food is going through the kitchen like that, it's not sat around, then it should be okay.
Okay. Thank you.
Yeah, go and do it.
Wonderful.
Go for it, Roz.
Brilliant. So I think that's all that we've got time for this evening, unfortunately. But I just want to say again, thank you so much for joining us this evening, Louise. That's been absolutely wonderful and incredibly enlightening as well. And I hope everybody has found the session really, really useful. I know I certainly have. So, we will be sharing the content on the website in due course as well. So if ever you need any support from us or anything, do get in touch. But, it's been wonderful to see you all this evening, and have a lovely evening.
Yeah, thank you for the invite, and I hope that there was a little bit of help there. And like I say, you know where we are if you need us.
Brilliant.
Thank you.
Bye, everyone. Have a great evening.
Bye.
Thanks.
Bye.